Hi, and welcome to another episode of Access California's podcast series. My name is Claire Courtwright. I am the Advocacy Director for Cal Voices. This is a two-part podcast series on a really important question in the federal and state law and policy arena right now. And it relates to institutionalization and this issue of what is an IMD and why does that matter? So because this is such an important issue at this time, both at the state and federal level, we thought we'd spend some time explaining the issue. It's very central to questions of care for people with serious mental illness and substance use disorders. So what is an IMD? An IMD is a federal term from the federal law. It stands for Institutions for Mental Diseases. And this is the legal definition in the federal law. It means a hospital, nursing facility, or other institutions where there's more than 16 beds in the facility. And what that facility primarily does is diagnose, treat, or care for persons with mental diseases, including when that care relates to medical attention, nursing care, and other related services. So why is this important? This definition pairs with a piece of history that is also the present law, and it's known as Medicaid's Institution for Mental Diseases, IMD exclusion. So what this is Medicaid, which is federal health insurance for people with low incomes and disabilities, that is funded by the federal government and funded by states jointly. So in California, the state of California has a Medicaid program called Medi-Cal, and Medi-Cal is jointly funded between the state of California and the federal government. It's about 50-50. But going way back in the history to when Medicaid was first passed at the federal level, it included what's called the IMD exclusion, or exclusion for payments for folks that are in institutions for mental disease. And people might ask why. Why does this IMD exclusion exist, and what does it really mean? The IMD exclusion was part of the original push for deinstitutionalization of people with serious mental illness. So back in the bad old days, the food, clothing, and shelter, medical care, psychiatric treatment, all of that for people with serious mental illness and others too, right? There's a history of this with intellectual and developmental disabilities and other folks as well. But all of that care for that population of people was provided inside large institutions called state hospitals in California. And as drugs improved and attitudes changed, and we started to move away from these large state hospitals as the way in which we were going to provide for all these needs for people with serious mental illness. Part of that deinstitutionalization is this IMD exclusion in Medicaid. And it is there to discourage states from keeping folks with serious mental illness in institutions for mental disease. So it was meant to discourage institutionalization. And how it discourages it is the federal government says, look, states, you can have these facilities that are over 16 beds and they're primarily engaged in the treatment of people with mental illness. Those are legal. You can have them. Whether they are locked or unlocked, if they meet the definition of this IMD, then the federal government will not pay for any portion of that, right? They're not going to pay for the roof over your head. They're not going to pay for the psychiatrist that works there. The states will have to pay for that on their own. And so this IMD exclusion has become, over time, a major battleground with respect to what health insurance should cover, does cover, access to services for folks, and also deinstitutionalization, and whether we are moving backwards towards this model of um, hospitals or long-term residential care facilities as, you know, the primary housing option or only housing option or only care option for folks with especially the most serious and unremittent mental illness. So just as a little bit of a review of just what I said. So who pays for an IMD when they exist? Um, Traditionally speaking, Medicaid will not pay for it. So the federal government is not paying for that. So what that ends up meaning is that the financial responsibility for folks that are staying in IMDs, whether the door is locked or unlocked, falls 100% to be paid by the state of California. And I recently learned, looking into it, that substance use disorders are considered to be under the federal definition of mental diseases. So that IMD exclusion should also apply to facilities over 16 beds, you know, inpatient facilities for substance use disorder. And then, so what is the name of the bucket of money in the state of California that pays for these IMDs? Is realignment dollars. And those realignment dollars have another purpose as well, besides hospitalization, which is that they can also pay for the half share of cost on other Medi-Cal services. And so again, how this kind of regrounding, how this relates to institutionalization, you know, going back in the history, what did people think it meant to be institutionalized? And it really was focused on these sort of all-inclusive care facilities. So again, whether the door was locked, whether the door was not locked, that was considered a form of institutionalization. And when California did what's called deinstitutionalize, shortly after Medicaid came into being, about 1968, I think is when we passed the Lanterman-Petra-Short Act. And what that did was not eliminate institutionalization or the ability of the state to place people long-term, including for the rest of their lives, in locked state hospitals. What it did was limit who could be long-term institutionalized to only those people who were first conserved with due process, with hearings. And then short-term institutionalization was limited to psychiatric holds. So all of these things are all in the same sort of bucket of considerations. And so, you know, what we typically think of as an acute psychiatric hospital, a mental hospital, if it's over 16 beds, it's an IMD, and the state is paying for that without assistance from Medicaid, traditionally speaking. And the attitude of the federal government historically is these are all choices of the state. If the state wants to have large institutions over 16 beds and wants to have conservatorship laws and wants to place people in care facilities, states can do all that, but they have to pay for it themselves. And so as this conversation about homelessness and the intersections of homelessness and mental illness and substance use disorders have become such a national conversation, a conversation that's happening in every state, not just California. A lot of folks have looked at reinstitutionalizing people in the traditional sense as a potential solution. And so you really have to realize that many issues are being rolled into one and try to take them back apart, because there is a difference between staying inpatient in what qualifies as an IMD because you want to be there and you are accepting that care, and you know, being in an IMD against your will on a psychiatric hold, which is short-term institutionalization, or you're stuck there long-term because you're conserved. And so when these issues are not pulled apart, and the funding question is not addressing the issue of voluntary versus involuntary, things start to get very murky indeed, because there has been a push at the federal level. Here's one example, Richie Torres, but there's been many others, um, where folks at the federal level are saying, look, we have homelessness problems across the United States, a real impediment to people receiving treatment for mental illness or SUD in IMDs is this exclusion, this IMD exclusion at the federal level. The federal government is not helping the states pay for this, traditionally speaking. And so we don't have access to care, right? It can be a burden on the state to fund these things out of their own state tax revenues. And as a result, do we really have the inpatient rehabs for SUD that we want? Do people really have access to acute hospitalization if that's what they need? Do we have, maybe even step downs, facilities that are unlocked but over 16 beds, so they're IMDs? And do folks have access to that? Is there an insurance payer? Is there a payer at the state level that is willing to pony up those dollars and support that infrastructure so that those people have access to those services? But again, that, talking about it that way scuttles the other side of the issue, or mixes it in with the other side of the issue, is, okay, but what if the patients aren't voluntary, right? What if, by removing the Medicaid exclusion, right, you're not only, excuse me, removing the IMD exclusion, you're not only removing it for the folks that want to access care on a voluntary basis, you're removing it for the folks that are being institutionalized or could be institutionalized under these conservatorship laws that in California now apply to SUD, and also under outpatient forms of that are expanding as well, right? So like the CARE Act is an example, right? The court in the CARE Act, even though you're not conserved and you haven't had that level of due process, and you're not as impaired as you allegedly are under a conservatorship, these courts now have the ability to place you in a facility, right? Place you in a clinical care facility. So that's why this issue is so hot right now, and why it is so important to so many people, and why it is so controversial. Because when you don't distinguish, when you're saying, well, Medicaid should pay for people to receive treatment in a rehab that's over 16 beds, but they're not distinguishing between voluntary and involuntary. Again, that's where this gets very controversial. And the IMD exclusion has been a target from politicians across the spectrum, who identify it as an impediment to getting folks off the streets and into, these sort of all-inclusive care facilities for mental illness, SUD. And so you can see, this is just another example. If you Google this, dozens of articles will come up, but people have introduced legislation at the federal level. There has been a look at this by the Congressional Budget Office. So they just sort of, analyze things and from a cost perspective. And you can see that the way this conversation is going, at least in the media, is that people link a supposed shortage of psychiatric hospital beds to this IMD exclusion and the inability, traditionally speaking, of getting the federal government to kick in half for this type of facility. So that's one of the very strong narratives out there is, we can't even maintain these hospital beds or expand these hospital beds, because the state having to pay for this on their own without some money kicked in from the federal government, is too burdensome. And so there's a lack of access. Of course, the other flip side of that is that there's plenty of evidence, and you can read Rob Wapon's book, Your Consent is Not Required, that there's also an explosion of involuntary treatment laws, both expanding conservatorship criteria, which allow for that long-term institutionalization, whether in a locked IMD or in an unlocked IMD or in a, unlocked psychiatric health facility that's under 16 beds. Um, so that, but then in addition to that, the explosion of short-term institutionalization, which also typically takes place, in IMDs because they're considered uh, efficient for the purpose, cost effective if you have a 200-bed hospital versus a 16-bed hospital. So this is a very hot topic and controversial thing that is happening in politics nationally and is impacting very much in the state of California. So just recap, like, what's all the fuss about? It's this issue of who will pay to house the people that are disabled with serious mental illness or SUD, including folks that are conserved, and who, by the way, the legal criteria of that is directly related in California and across the country to being unable to provide for your own food, clothing, and shelter due to a disability. And, really, what are the needs of persons beyond a roof over their head when they're disabled? What sort of things do they need assistance with? What sort of things do they want assistance with? Um, that can come in a great variety of needs, right? My needs right now as a person with serious mental illness are not likely to be the same as my needs when I'm 75 with a serious mental illness. And so we haven't really had a conversation that I've seen, at least publicly in California or nationally, just sort of doing a needs assessment and saying, well, what is this population of people that needs financial assistance to be housed? What are the variety of settings and services that would support people to be housed, to be long term, I guess you would say stabilized in housing, but that also involves a component of choice on behalf of the person and agency, um, and that the type of living arrangement that they have access to is, you know, non-segregated, dignified, safe, appropriate, but also what they want, right? A place that they would consent to live. And so this is all, as I said, like, all these issues have really not, the pieces of them haven't been teased apart. And instead it all gets mixed up in this big, IMD um, uh, bucket sort of conversation without distinguishing voluntary from involuntary, without doing a needs assessment of, like, who is the population that needs a public subsidy, needs a public benefit to be housed? What are their other needs in addition to housing that would allow them to remain housed, especially independently housed, or housed to the degree of independence that they would like, or allows them to move through different settings and have different housing options available as they recover, and doesn't pigeonhole people into we're willing for you to pay, we're willing to pay for you to live in a nursing home even though you're 45 for the rest of your life because you need assistance with money management or meal preparation or activities of daily living. Like, we think this is fine for you. And if you don't want to be here, or you want to sort of obtain some skills to be more independent, or you have goals of your own, goals and desires of your own, too bad, this is what you get. And so that's part of the real concern and conversation amongst our community, but also very much in the IDD community that has also dealt with, trying to have independent living. We have centers for independent living in California. And then, again, related to all of this is that reinstitutionalization is very much a thing. Um, and it's also happening in an era of these expanding civil and criminal court systems that are creating all these new and collateral pathways into being conserved, which again is the legal front door to the institution in California, or to institutionalization, both locked and unlocked, segregated living in segregated facilities with a very regimented life. And, shout out also to how much of this is legally untested. At least in California, we have expanded officially a number of civil outpatient and inpatient laws, and the basis of whether or not those are really acceptable gets tested in the courts as people challenge them, right? So we now officially have a law on the book that says, if you have a severe substance use disorder and you're unable to protect yourself, which is essentially, not very well defined or not defined, then we can place you under a conservatorship and we can institutionalize you through that conservatorship. Long-term locked facility, long-term unlocked facility, but whether or not, having a substance use disorder and being unable to protect yourself is outside of the bounds of the few constitutional precedents from the Supreme Court that exist around when you can and cannot institutionalize someone, that is untested. We don't know. So those are all these issues are very much coming to a head right now, both nationally and in the state of California. And so stay tuned for part 2 of this podcast. And in part 2, we'll talk about IMDs in California and why this is such a critical and hot topic right now in California.